Okay, let's unpack this. 7% of elderly individuals in the U.S. have renovascular disease.
7%.
That's a surprising number, isn't it? And it immediately tells you this isn't some obscure condition.
Not at all.
But hold on, what exactly is renovascular disease? It's not just one single thing, is it?
No, you're right. It's really a spectrum. We're talking about a whole range of issues affecting the renal arteries.
Those crucial blood vessels feeding the kidneys.
Exactly. And how well those vital organs get the blood flow they need.
Right. So for this deep dive, we're digging into Rutherford's vascular surgery and endovascular therapy.
That's the plan. Specifically, Section 19 on Renovascular Disease, chapters 127 through 132.
Think of this as, well, a condensed guide. A practical instruction manual, maybe?
Kind of, yeah. Our mission is to pull out the essentials from these chapters, focusing on what a vascular surgeon really needs to know to manage this complex condition effectively.
Okay, so Chapter 127 gets us started. Understanding renovascular disease. What's the core issue we're grappling with here?
At its heart, RVD covers disorders that mess with the structure of the renal arteries.
And therefore, the blood flow to the kidneys.
Exactly. And the big clinical worries that pop up are hypertension, often severe, hard to control,
Right.
and a decline in kidney function. Both of which, as you know, can really drive cardiovascular problems, lead to dialysis.
And unfortunately, increase mortality risk.
Yeah. So the key insight maybe is that in renovascular hypertension, unlike the more common kind, the high blood pressure is often a symptom of that local kidney issue.
Which means fixing that local issue could potentially help in the right patients.
Precisely. In carefully selected cases, yes.
Makes sense. So what are the usual suspects causing these plumbing problems in the renal arteries?
Well, most common culprit, by a long shot, is atherosclerotic renal artery stenosis, RAS.
Just like plaque buildup elsewhere, coronary arteries, legs.
Exactly the same process, especially common in older adults.
Mhm.
Rutherford's actually has a figure, 127.1, showing this typical bilateral narrowing. But it's not the only cause. You also see fibromuscular dysplasia, FMD.
The string of beads.
That's the one. Very characteristic look on imaging figure 127.3 shows it well. And that's important because it often affects younger people.
You could distinction. Any others?
Less common things like dissections, aneurysms, maybe trauma, different types of arteritis.
Inflammation.
Right, inflammation, and even developmental issues like mid-aortic syndrome, which you see more in kids.
Okay.
But look, the vast majority you'll encounter in older adults, it's going to be atherosclerotic RAS. FND is just important to recognize because it looks different and hits a younger group.
Got it. Now, how does messing with the kidney's blood supply actually trigger high blood pressure? What's the mechanism?
This is where the renin-angiotensin-aldosterone system, the RAAS, comes in.
Yes, the RAAS cascade.
Exactly. When a renal artery narrows, the kidney thinks, hey, I'm not getting enough blood pressure.
So it tries to fix it.
Right. The juxtaglomerular apparatus releases renin. Renin kicks off that cascade, ultimately making angiotensin the exon, or ANG2.
And ANG2 is potent stuff.
Very potent. It constricts blood vessels, vasoconstriction, and makes the body hold on to fluid. Both actions push blood pressure up.
Through specific receptors.
Yeah, ATR1 and ATR2. ATR1 is mostly responsible for the vasoconstriction and proliferative effects. There's also this more complex idea of tissue-specific RAAS within the kidney itself.
So it can amplify the effect locally?
Kind of, yeah. It's different from essential hypertension, where the trigger isn't necessarily that reduced kidney blood flow.
So the kidney is sounding the alarm, cranking up the pressure.
But that doesn't fix the underlying blockage.
Creates a vicious cycle. Okay. What about the kidney itself? Does the lack of blood flow hurt the organ directly?
Absolutely. Prolonged reduction leads to ischemic nephropathy, basically kidney damage from lack of oxygen and nutrients.
How?
Well, the lower filtration pressure directly impairs its filtering job. Plus, that chronic RAAS activation, the excess ANG2 and aldosterone, stimulates profibrotic factors.
Like TGF-beta.
TGF-beta, EDGF.
Yeah.
These signal the kidney cells to lay down scar tissue, fibrosis.
So scarring within the kidney structure.
Exactly. Glomerulosclerosis, tubulointerstitial injury. And there's also a theory that bits of plaque, microemboli, can break off and cause further damage.
Nasty stuff. Who's most likely to get RVD? Is it purely an age thing?
Well, it is more common in the elderly, especially those who already have atherosclerosis elsewhere. CAD, carotid disease, PA.
Rutherford's table 127.1 highlights those connections, right?
Yes, it does. Those are high-risk groups. But it can happen in younger folks, too, particularly with FMD or developmental issues. Autopsy studies definitely show RAS prevalence climbing with age.
And it often exists alongside other vascular problems.
Definitely. It doesn't usually happen in isolation.
Okay, so someone develops RAS. If it's not treated, what typically happens over time?
Good question. You have to think about two things. The anatomical progression, the narrowing itself getting worse.
Does it?
Yeah, studies using angiography and duplex ultrasound show it can worsen over time in a fair number of patients.
Any factors that predict that?
Seems like older age, higher systolic BP, smoking, being female, maybe poor hypertension control.
Mhm.
Those are associated with progression. And in severe cases, it can even block off completely.
Wow. And the functional side, the kidney function.
Well, that chronic RAS activation and high BP take their toll.
Yeah.
Progressive kidney damage. And remember, serum creatinine, the common blood test.
Doesn't rise until significant damage is done.
Often, yeah. Significant nephron loss has to occur first. So kidney shrinkage, atrophy, which you can see on imaging like RDU, might be an earlier warning sign.
So function can decline even if the stenosis itself doesn't look much worse.
Studies suggest yes. Absolutely. And ischemic nephropathy from RAS almost always comes with severe hypertension. A real red flag is acute kidney injury right after starting an ACE inhibitor or an ARB.
Why is that?
It suggests bilateral RAS, where both kidneys are really dependent on Ang2 to maintain their filtration pressure. Take that away, and function can tank.
Okay, good clinical pearl. Any other presentations?
Patients might present in a hypertensive crisis. On exam, you'd look for severe HTN, maybe peripheral edema, and crucially, an abdominal bruit.
That whooshing sound over the renal arteries?
Exactly. In kids, it can be different. Decreased lowered leg pulses might point to aortic coarctation. Rutherford's table 127.3 lists other things to consider, the differential diagnoses.
What about lab tests? What can they add?
Well, the standard hypertension workup urinalysis, chemistries, glucose, lipids, EKG.
Basic stuff.
Right. BUN and creatinine might be up, but again, not always early on. The EKG could show LV hypertrophy from long-term high pressure.
What about renin levels?
Systemic renin levels alone. Generally not that helpful, surprisingly. In diabetics, check urinary albumin. And it's crucial to think about other causes of secondary hypertension.
So.
Well, if potassium is spontaneously low or drops hard with diuretics, think Conn syndrome primary hypaldosteronism.
Okay.
And if you have episodic hypertension with headache, palpitations, sweating, think pheochromocytoma.
Right, rule those out. So history, exam, basic labs point us in a direction. How do we actually see the renal arteries? What's the imaging strategy?
This is critical. Renal duplex ultrasound, RDU, is often the first-line screening tool.
Pros and cons.
Pros, best case of fast, non-invasive, pretty accurate if the tech is good, reproducible, no radiation or contrast, cheap,
Cons.
but very operator-dependent. Less useful for other types of RVD besides stenosis. Patient factors like obesity can limit views.
What are you looking for on RDU?
Key criteria for significant stenosis include peak systolic velocity, PSV, over 200 centimeters in the main renal artery, especially with post-stenotic turbulence.
Some use the renal aortic ratio, RAR.
Some do, but the authors here find PSV alone more reliable. You can also look at waveforms within the kidney. A delayed systolic upstroke, acceleration time over 100 milliseconds, is a strong sign of proximal stenosis. Table 127.4 compares accuracy.
So RDU is the practical first step for most.
Generally, yeah. Good non-invasive hemodynamic info,
Yeah.
but know its limits.
Okay, what's next if RDU isn't clear or you need more detail?
Then you might move to CT angiography, CTA,
Advantages?
excellent 3D views, widely available, less technically demanding maybe than RDU or MRA,
Disadvantages?
radiation, and iodinated contrast, which carry that risk of kidney damage, nephrotoxicity,
But it's accurate.
very high sensitivity, specificity, accuracy for main renal artery lesions, according to table 127.4. Plus, it shows surrounding tissues, which helps if you're planning surgery.
What about MRA? Magnetic resonance angiography.
MRA's big pluses are no radiation and no iodinated contrast, often preferred in children for that reason.
Downsides?
Longer scan times, lower spatial resolution than CTA or DSA, issues with claustrophobia, metal implants, and crucially, the gadolinium contrast used is contraindicated if kidney function is really poor, eGFR, less than 30.
Why?
Risk of nephrogenic systemic fibrosis, NSF, a nasty complication. MRA is good at finding critical RAS, but can sometimes overestimate how bad the stenosis is. Again, table 127.4 compares.
So several non-invasive options. When do you do the gold standard digital subtraction angiography, DSA?
Nowadays, with good non-invasive tests, DSA is usually reserved for patients who are already heading towards a revascularization procedure.
Because it's invasive.
Exactly. But it gives the most precise anatomical detail, accessory arteries, branch disease, the other kidney supply, the aorta, essential for planning intervention.
What if the patient has poor kidney function?
Then you have to be really careful. Pre-procedure hydration is key. Minimize contrast volume, maybe use isoosmolar contrast or even CO2 angiography. Figure 127.5 shows CO2 angio.
Okay, so we can see the blockage, but how do we know if fixing it will actually help the patient's blood pressure or kidney function? That's the million-dollar question, right?
It really is. Predicting benefit has been tough. Surgeons might look at direct pressure gradient measurements during DSA, the pressure drop across the stenosis.
A big drop suggests it's significant.
That's the idea. Or seeing the kidney shrink on RDU. Those are surrogates for significant hypoperfusion. Older tests like split renal function studies or renal vein renin assays had limitations.
All right, let's say we've diagnosed renovascular hypertension. What are the treatment options outlined in Rutherford's?
Well, the first point is that RAS is linked to higher cardiovascular risk progression, kidney loss, dialysis.
Yeah, we covered that.
But, and this is a big but, the role of fixing it, revascularization, especially for the common atherosclerotic type, has been really challenged.
Because medical treatments got better?
Partly that, and partly because big trials, level I data, question the benefit of stenting for many of these patients.
So the approach has shifted.
Definitely. Most centers now are more selective, reserving revascularization for severe atherosclerotic RAS cases or for non-atherosclerotic types like FMD.
So medical management is foundational.
Absolutely. It's the cornerstone. Recognize that kidney dysfunction is often multifactorial. Regular monitoring of kidney function, checking eGFR, involving a nephrologist if needed. That's crucial.
Lifestyle changes too.
Yep. Weight loss, glucose control, and diabetics. And in experienced centers, maybe annual RDU follow-up for known RAS, or after revascularization to check patency and kidney size.
Especially after stenting because of restenosis risk.
Exactly. And definitely consider RDU if hypertension suddenly worsens or kidney function drops. Aggressive BP control is key target, similar to essential hypertension, maybe even lower for some.
Okay. What about actually fixing the narrowed artery, revascularization?
Historically, open surgery was more common.
How does it hold up?
Open repair is very durable. Patency rates over 90% long-term. We still consider it in good risk patients with, say, bilateral RAS or branch disease who fail medical therapy. Also in kids with developmental RVD.
What about outcomes?
The Wake Forest data showed about 4.6% 30-day mortality overall, higher in those with kidney failure. Survival was really tied to how well the kidney function recovered after surgery.
And blood pressure.
In our experience, open repair did better than stenting for improving or curing hypertension.
But major surgery.
It's more invasive, higher mortality risk than endovascular. So fewer open repairs are done now.
Which brings us to endovascular treatment, angioplasty and stenting.
Right. Restenosis rates after stenting, while better, are still significant, often over 10% in recent trials. And the BP response can be variable.
So, given those big trials, Astral, Coral, how do you decide who gets endovascular therapy? Let's jump into Chapter 129, indications.
Okay, the key takeaway from Astral is that prophylactic stenting, just fixing a narrowing that isn't causing trouble, doesn't help.
So don't just stent it because it's there.
Exactly. Current guidelines favor intervention only for hemodynamically significant stenosis.
Meaning it's actually causing problems.
Right. Problems like severe, hard-to-control hypertension with or without kidney issues, or hypertension causing cardiac problems like flash pulmonary edema. Hypertensive emergencies, too.
What about just for lowering BP?
That's where Astral and Coral really dampened enthusiasm. Fixing the stenosis didn't reliably translate into better BP control or preventing cardiovascular or renal events compared to meds alone.
So intervention just for BP improvement alone is generally out?
Pretty much. Limited to truly refractory severe HTN or HTN with target organ damage.
Okay. If you do intervene, how is success measured?
There's technical success getting the artery open, less than 30% residual stenosis on angio, full stent coverage. Confirming with pressure gradients, aiming for less than 10 millimeter HG drop is good too.
But that's just the plumbing. What about the patient?
Right. Patient benefit is about clinical response. Did the hypertension get better, cured, improved, failed? Did kidney function stabilize or improve? Looking at eGFR, creatinine, kidney size, often a 20% eGFR change is used.
So technical success doesn't guarantee clinical success.
Not always, no. The real win is sustained improvement in DP and/or kidney function.
What are the typical late outcomes after stenting for atherosclerotic RAS?
Well, stent patency is maybe around 80% at 5 years. Hypertension response, cure is uncommon. Improvement or failure is more typical.
Astral and coral showed minimal BP benefit.
Minimal compared to medical therapy alone, yes. Small drop in diastolic and astral, small drop in systolic and coral, not much change in meds needed. Some case series show improvement, but failure is also common.
And kidney function.
Some studies suggest that if kidney function improves after revascularization, survival might be better. But whether just stabilizing it or slowing the decline helps is less clear.
Predictors for renal function improvement.
Things like bilateral disease, worse baseline creatinine, rapid decline beforehand, maybe smaller kidney size pre-op, those seem to be associated with better response. BNP levels have been looked at too.
What about restenosis, the narrowing coming back?
It's a real issue. Reported rates vary hugely, 5 to 66%, depending on follow-up and how you define it. Seems more common in women. Metabolic syndrome.
And survival.
Limited long-term data. Astral showed no survival benefit with stenting. Some older series link baseline kidney dysfunction and lack of renal function improvement post-stenting with worse survival and progression to dialysis.
Okay, let's talk technique. What are the key considerations for the surgeon doing the procedure?
Anatomy first. Renal arteries usually come off the aorta at an angle, so you need oblique views on imaging. Multiple renal arteries are common, 18% or so.
That's sad.
Distal main renal artery is typically 5-6 millimeter. Endo is mostly for lesions near the origin, the ostium, or proximal main artery. Branch disease is trickier.
Big concern is contrast nephropathy.
Huge concern. These patients often have iffy kidneys already, plus diabetes, HTN, CHF. Assess the risk. Hydrate well with isotonic saline. Use the least amount of isoosmolar or non-ionic contrast possible, maybe half strength.
And if eGFR is really low, like under 30,
Consider CO2 angiography, either primary or adjunct.
medical management continues.
Oh, yeah. Keep managing the BP.
Angioplasty versus stenting.
Primary angioplasty, just the balloon, is often preferred for FMD. For osteoatherosclerotic RAS, primary stenting usually gives better technical success, lower restenosis. Angioplasty alone might be used for restenosis or non-osteal lesions.
Access route.
Ultrasound-guided common femoral is standard. Sometimes contralateral access helps with tricky osteal lesions. Left brachial is an alternative if femoral doesn't work, but more complications. Radial is tough.
Walk us through the procedure itself.
Okay, patient gets heparin. Access the artery, cross the lesion with a .014 wire. Advance a guide sheet to the origin for support.
Embolic protection. Little bits breaking off.
Can't happen. You can use distal protection devices, balloons to block flow and aspirate debris, or filters. None are specifically FDA approved for renal arteries, though.
Do they help?
Some case series suggest fewer acute kidney issues. The RESIST trial showed benefit with one filter type, but only with ipsiximab, especially in patients with worse kidney function.
So wire across, maybe protection device. Then what?
Might need predilatation with a small balloon. Then inflate the main angioplasty balloon, note the waist as it inflates. Persistent pain during inflation is bad, could mean injury. Keep wider access.
Physician's choice.
Usually balloon expandable stents for good radial strength. Self-expanding less common. For osteal disease, place it protruding 1 to 2 millimeters into the aorta. Use contrast puffs for guidance. Deploy the stent by inflating its balloon.
Covered or bare metal?
Both used. No strong evidence favoring covered stents specifically here. Many stents now come pre-mounted, so you might skip predilatation.
What if there's still a waist after stenting?
Can post-dilate carefully, but don't oversize, especially in calcified arteries. Only dilate to the diameter of the normal vessel segments.
How do you check the result?
Completion angio, maybe IVUS, and measure the pressure gradient across the stent. Aim for 30% residual stenosis and 10 millimeter Hg gradient.
Post-procedure care.
Monitor the access site, hemodynamics. Start dual antiplatelet therapy beforehand. Usually aspirin and clopidogrel, continue clopidogrel for at least 30 days, aspirin and statin indefinitely. Watch for complications like rupture. Chapter 129 has a good algorithm.
Okay, shifting gears to Chapter 131, aneurysms and AV fistulae. Let's start with renal artery aneurysms, RAAs. How common?
Pretty rare. Most surgeons don't see many. Autopsy studies suggest low incidence, maybe underestimated. Imaging studies find them a bit more often, maybe close to 1%.
What causes them? Different types?
Yeah. True aneurysms are often degenerative, maybe linked to congenital weakness, often at bifurcations, sometimes multiple. Saccular or pouch-like, fusiform or more spindle-shaped, often with atherosclerosis or poststenotic dilatation.
False aneurysms.
Those are from trauma or procedures like pseudoaneurysms. Dissections within the renal artery are rare but can cause them, more common in FMD. And you can get small and treated renal aneurysms too.
How do they present? When do they need attention?
Most are found incidentally totally asymptomatic. The big worry is rupture, acute pain, low blood pressure. It's an emergency.
Other symptoms.
It can cause hypertension through various mechanisms, emboli, compression, renin release. But be careful blaming HTN solely on the aneurysm when deciding treatment. Pain is unusual unless it's rupturing or inflamed. Hematuria if it erodes into the collecting system. Dissection causes acute pain, hematuria, HTN.
So when do you intervene?
Definitely for rupture, acute dissection, or clearer symptoms. Asymptomatic ones are trickier. Depends on rupture risk versus intervention risk.
What increases rupture risk?
Traditionally, size over 2 centimeters was the main trigger, but that's maybe too aggressive now. Other factors: ongoing hypertension, pregnancy, big risk factor, certain connective tissue diseases, being symptomatic, being a woman of childbearing age. Overall rupture risk is probably low, 3%, but mortality, if it happens, is significant.
Treatment options.
For small, stable, asymptomatic ones, watchful waiting with imaging and BP control might be okay.
Intervention.
Open surgical repair is complex, more so than RAAS surgery, especially if it involves branches deep in the kidney. Requires specialized techniques, aneurysmorraphy, bypass grafts, autologous vein or artery, sometimes even bench surgery with autotransplantation.
Bench surgery, taking the kidney out.
Yeah, repairing it on the bench with cold perfusion, then putting it back, sometimes in the iliac fossa. Elective open repair by experienced teams has low mortality.
What about endovascular?
Increasingly used, especially for degenerative types, transcatheter embolization with coils or liquid agents to block off the aneurysm sac while keeping the main artery open. Stent grafts can exclude some aneurysms, particularly if they don't involve branches.
How do outcomes compare?
A nationwide study showed more endo repairs being done, but complication rates for both open and endo were over 10%, suggesting maybe we need to reevaluate who needs repair and perhaps be less aggressive. For FMD with poststenotic aneurysms, fixing the stenosis might be enough. Intrarenal ones often need partial nephrectomy. Chapter 131 has algorithms.
What about renal AVMs and AVFs, arteriovenous malformations and fistulae?
Also uncommon. AVMs are congenital tangles of arteries and veins. AVFs are acquired connections, usually traumatic.
Most common cause of AVF.
Percutaneous renal biopsy, actually, though often asymptomatic, can cause hematuria, HTN, heart failure F large, rupture. Diagnosis is usually angiography, which is also key for planning treatment. Asymptomatic, often left alone. Symptomatic ones. Endovascular embolization is now the preferred approach, replacing surgery most of the time.
How does embolization work here?
Renal arteries are end arteries, so you can block off the feeding vessels to the AVM-AVF using coils, glues, particles, balloons, trying to preserve normal kidney tissue. Covered stents can sometimes exclude large AVFs. Surgery is still an option for really complex ones near the main vessels. Again, algorithms in the chapter guide this.
Okay, last major topic. Chapter 132, Developmental Disorders in Children. Sounds very specialized.
It absolutely is. Complex area, pathogenesis not fully understood, but interventions, open or endo, can really help selected kids.
What kind of disorders?
Abdominal aortic coarctation is one narrowing of the aorta, classified by location relative to the renal arteries. Suprarenal, intrarenal, infrarenal. Often linked to genetic syndromes like neurofibromatosis 1, NF1, Williams syndrome, or inflammation like Takayasu's.
And these often involve the renal arteries.
Very often. Aortic coarctations frequently occur with stenosis of the renal and splenic gut arteries. In kids, these stenoses are often developmental, true hypoplasia, linked to NF1. The narrowings are typically right at the origin, the ostium.
How do these present in children?
Renal artery disease is a major cause of pediatric hypertension, often severe and refractory to meds. Aortic narrowing makes it worse. Kids might have exercise fatigue, rarely claudication. Gut artery involvement rarely causes symptoms but can lead to pain after eating, weight loss. Many kids are initially asymptomatic despite high BP.
Complications of chronic HTN in kids.
Impaired kidney growth, kidney failure, stroke, hypertensive encephalopathy, failure to thrive, LV hypertrophy. Serious stuff.
Diagnosis.
Ultrasound is a starting point. CTA or MRA often used first line now with low-dose protocols. Angiography is usually needed for planning intervention.
Treatment. Starts with medical.
Yes, manage the hypertension aggressively. Could be tricky in young kids. Be cautious with AC SARBs if bilateral disease is suspected.
Surgical treatment.
For aortic coarctation, often patch aortoplasty or bypass graft. EPTFE, usually done with renal splanchnic reconstruction if needed. Younger age might mean higher chance of reoperation later as they grow. Open surgery outcomes are generally good for BP control.
Renal artery reconstruction in kids.
Depends on the lesion. Reimplanting the renal artery into the aorta is common. Bypass grafts, vein, hypogastric artery, or endarterectomy are other options. Large pediatric series show good results with open surgery, high rates of HTN cure or improvement, low mortality.
What about endovascular for kids?
It's used increasingly, especially for FMD. For developmental aortic or renal narrowings, results are more mixed. Higher complication rates, higher stenosis reintervention rates compared to open surgery. Developmental lesions tend to recoil after angioplasty, often needing stents, which is problematic in growing children. Subsequent open surgery after failed endo is harder.
So still controversial.
Yes, the role of endo for developmental RAS in kids is definitely controversial. Open surgery, often still preferred for durability. Managing these kids really needs a multidisciplinary team. Chapter 132 has an algorithm for this too.
Wow, that's an incredible amount of detail across those chapters, an amazing resource. So to boil it all down, what are the absolute key takeaways for a vascular surgeon trying to navigate renovascular disease based on this deep dive into Rutherford's?
Okay, first, RVD is diverse. Atherosclerotic RAS is common in adults, but remember FMD, aneurysms, AVFs, and the unique pediatric developmental stuff.
Second,
Diagnosis needs strategy. RDU first, then C-TAMRA for anatomy, DSA mostly just before intervention.
third, revascularization for atherosclerotic RAS is now more selective.
Exactly. Medical therapy is king. Intervene for severe refractory HTN or specific syndromes. Open surgery is durable but invasive. Endo is less invasive but has limitations, especially long-term benefit in atherosclerotic RAS based on trials like Astral and Coral.
Fourth, aneurysms and AVFs need individualized plans.
Right. Based on size, symptoms, rupture risk. Endo is gaining ground, especially for AVFs.
And finally,
Pediatric developmental disease is its own world. Needs a multidisciplinary team, often favors durable open repair.
okay, that really synthesizes it well. It leads to a provocative thought, doesn't it? Considering how much medical therapy has improved and how endovascular tech keeps advancing.
Where does that leave us?
Exactly. How will we refine who really benefits from intervention in the future? Will less invasive options continue to push the boundaries, maybe even challenging open surgery more in select cases?
It really forces you to think about individualizing treatment, doesn't it? Based on the specific cause, atherosclerosis versus FMD versus aneurysm versus developmental, and the whole patient picture.
Absolutely. The constant evolution in diagnosis, medical treatment, and interventions makes this field so dynamic. This deep dive into Rutherford's gives such a solid foundation for understanding the current state of play.
Agreed. It's a critical resource, and hopefully this discussion helps you navigate those chapters and apply the knowledge effectively.